For the next oral presentation is Bridging Gaps in Survivorship Care in IMICs, a multi-center study on caregivers' perceptions of late effects in pediatric cancer in Thailand, presented by Praeploy Amornsillaphachai from Phramongkutklao College of Medicine.
Thank you so much for introducing me. Good morning, esteemed judges and colleagues. I'm Praeploy Amornsillaphachai from Phramongkutklao College of Medicine, presenting Bridging Gaps in Survivorship Care in Low and Middle Income Countries. This work represents the first multi-center study in Thailand, exploring how healthcare providers perceive and practice late-effects care in pediatric oncology. There are no conflicts of interest to declare. Funding was provided by Phramongkutklao College of Medicine and the Thai Society of Hematology. Over the past few decades, childhood cancer survival has improved remarkably in the United States, worldwide, and here in Thailand. Yet, as more patients survive, late effects such as cardiovascular and neurological complications have become the major causes of long-term morbidity and mortality, illustrated in the yellow curve rising over time. This can be summarized simply. First, advances in cancer therapy have led to increased survival, but inevitably, this has also led to increased late effects. Unlike high-income countries with structured survivorship systems, Thailand and other low and middle-income countries lack both programs and guidelines. Understanding healthcare providers' perspectives is the essential first step toward creating a practical, context-based solutions beyond written guidelines. Our primary goal was to assess healthcare providers' knowledge and perceptions towards late effects care, with a secondary goal to identify the factors shaping these outcomes. We developed the DALIT survey, Doctor Assessment in Late Effect Treatment. This is the first survey in Thailand exploring the physician's perceptions in late effects care, using Children Oncology Group long-term follow-up guidelines, along with expert consensus. It covered three main domains: knowledge, experiences and accessibility, and system-level barriers. The responses were rated on 5-point Likert scale and standardized to 0 to 100 score, where higher scores indicate stronger alignment to the principles. The instrument showed a good reliability with a Cronbach's of alpha of 0.8. The data were collected through RateCap and distributed via Thai Pediatric Oncology Group Network, with oncologist leads sending it to their teams and following up to ensure participation. The analysis included descriptive statistics and regression models. We received 114 responses from 37 pediatric oncology centers nationwide, 43% response rate. Most of the respondents were female, with a mean age of 40 years and mean experience of 14 years. 36% were pediatric oncologists. Most worked in teaching hospitals. However, only 3 hospitals, or about 8% of the centers, had dedicated late effects clinic. We assessed the physician's alignment to Children Oncology Group long-term follow-up guideline, meaning how closely their responses match the established survivorship principles, scored from 0 to 100. We analyzed multiple factors such as age, expertise, institutional resources, using univariate and multivariate regression. None were significant, except for prior late effect training. Those with training scored 74%, comparing to 67% in those without. This slide shows the physician's experience and access to late effects care, analyzed by expertise, hospital types, and prior training. Pediatric oncologists reported higher confidence, better multidisciplinary team consultation. They also reported better intra-department collaboration. Those working in teaching hospitals scored higher across all domains, with significant differences in multidisciplinary team consultation and interdepartmental collaboration. Physicians with prior late effect training reported higher confidence and greater ease in multidisciplinary team consultation comparing to those without. Our main barriers included lack of one-stop service, time constraints, absence of national guideline, and limited providers' knowledge. Our findings show that, despite the improved pediatric cancer survival, Survivorship care remains under-recognized and unstructured. Training in late-effect care is essential to strengthen the provider's knowledge and confidence. In low and middle-income countries, we propose oncology-led model supported by multidisciplinary collaboration, ideally initiated in teaching hospitals before national expansion. However, several barriers still remain, which need further exploration. This study is limited by its self-reported data, cross-sectional design, and over-representation of pediatric oncologists. To fill this gap, we propose two-level model of care. The clinical level focuses on early survival identification, risk stratification, multidisciplinary follow-up clinic with individualized care plan. The policy level builds sustainability through the national guidelines, training programs, and funding under national registry. This framework lays the foundation for a structured, equitable survivorship system in Thailand. Although Phramongkutklao Hospital is among the few centers in Thailand with late effects clinic, it remains unstructured. To fill this gap, we launched a quality improvement project to create a locally adapted pilot clinic in collaboration with Institute for Healthcare Improvement and St. Jude Global from the United States. This pilot will translate the model into practice and serve as an example for expansion to other countries with similar resources. Lastly, I would like to express my deepest gratitude to my mentor, Dr. Shalini and Dr. Nawashai, for their constant guidance and inspiration. Sincere thanks to Thai Pediatric Oncology Group collaborators nationwide, SIOP 2025 and St. Jude Global for their support. Above all, I would like to thank the patients and the family whose strength gives true meaning to this work. I'd like to end with a saying from the hospital that first inspired me to pursue pediatric oncology. No child should die in the dawn of life. It reminds us our goal is not only to care, but to care, to make sure every survivor's story continues. Thank you, and I'm happy to take any questions.
What a truly insightful presentation. For the judges, do you have any comments or any questions?
Thank you for a very good presentation, and I think that it's very good that you can apply it into a future policy, and there are a lot of collaboration. But I just wonder what was your role in this research?
Thank you so much for the question. And I was super fortunate that I have several roles in this project. First, I helped the team develop the data-led survey by using the extensive literature review along with the expert consensus. I also conducted the pilot testing with 10 pediatric oncologists to ensure reliability. After that, I was the research coordinator contacting with the pediatric leads via the Thai Pediatric Oncologist Network along the country. And I cleaned the data, and I also conducted the analytic plan. And lastly, I was also the lead of manuscript editing.
So, how do you propose addressing identify the barriers of absence of one-stop service, given the multidisciplinary approach for the late effect care?
Thank you. This is actually a question that we have been thinking. So regarding this topic about the MDT, or multidisciplinary team referral system, that is actually reflects the low and middle income countries' constraint in the system. So regarding that, and our studies finding, so we did the quality improvement project. So to create the locally adapted pilot clinic here in Phramongkutklao Hospital, which combined the multidisciplinary team such as pediatric oncologists, of course, pediatric endocrinologists, the growth and development team, cardiologists, and something, and more of the subspecialists like this. So we create the pilot clinic to build a pilot system first to try in our teaching hospital because the teaching hospital is equipped with more equipments to detect cardiovascular neurotoxicology, something like that, here in Phramongkutklao Hospital. So we make sure that our study reflects the broader LMIC, the low and middle income countries' constraints, and will set as an example to use in other, hopefully in other hospitals and other countries in nearby.
Thank you.
Thank you so much.